Hello, let's look at chest pain, non-cardiac in origin. So non-cardiac chest pain is recurrent substernal chest pain or pressure or other chest discomfort believed to be unrelated to the heart after a reasonable cardiac evaluation. It is important to distinguish cardiac from non-cardiac chest pain. I don't think we have an issue with that, understanding that concept as nurses. However, this is a new way for us to discriminate as advanced practice nurses. The epidemiology is interesting, and it's also a clue. Most episodes of chest pain in the primary care clinic are of non-cardiac origin. About 67% of chest pain is related either to musculoskeletal, gastrointestinal, psychiatric, or pulmonary disorders. Only 16% is found to have a cardiac origin, and then the other 16% is idiopathic, just unexplainable. The diagnosis for chest pain is most often obtained with a detailed history, a physical exam, an ECG, or a chest radiograph if indicated. Ruling out cardiac causes for chest pain is the essential first step. So the pathogenesis is kind of interesting. Just as a review, the sympathetic chain, vagus, and phrenic nerves are all structures in the chest, and they have overlapping innervation. So, in other words, all the structures in the chest, including the chest wall, the esophagus, the lungs, heart, and diaphragm, have this overlapping innervation. So pain from different organs, including those in the abdomen, that abut the diaphragm, the liver, the spleen, and the stomach, may have similar referral patterns. In addition, patients may really have a difficult time localizing pain from deep structures, whereas involving more superficial structures such as chest wall or the pleural are much more easier to recognize or to discriminate. So how's a clinical presentation? Again, the history is crucial for diagnosis and management of pain. The history is going to really lead you along with thinking about the epidemiology and the pathophysiology of the origin of chest pain. If you can look on page 446 at table 104, it really focuses on careful questioning of chest pain with patients that complain of chest pain. And there's about 8 questions there that are specific. They really want you to hone down on asking about the quality of the pain. Can they describe their pain? The location of their pain, where is their pain? Intensity, how severe is it? The duration, how long does it last? Aggravation, what provokes your pain or makes it worse? Alleviation, what makes it better? We also include their past medical history, their family history, questioning about recent strenuous physical activity, whether that at play or work, heartburn, dysphagia, reflux, blood in stool, stress, drugs, medications, including over-the-counter meds. So you can see it's quite a comprehensive questioning. So on the physical exam, general appearance and vital signs are where we begin, and it's very important, particularly for chest pain. This is really about excluding cardiac disease versus non-cardiac chest pain. So the vital signs and the general appearance should appear normal in a non-cardiac. The neck exam has to be included in your assessing for adenopathy, vein distension, any trachea deviation. The examination of the chest has to include looking for rash or lesions or evidence of trauma. You've got to palpate the chest and assess range of motion of the upper body, percuss the chest for dullness, auscultate the lungs for abnormal breath sounds, and the heart for murmurs, extra heart sounds, and friction rubs. You also will include a thorough comprehensive exam of the abdomen for tenderness, organomegaly, bruit, and many patients with non-cardiac chest pain will actually have a normal exam. Diagnostically, 12-lead ECG is a standard. Normal ECG reduces the likelihood of an acute coronary syndrome by 70 to 90%, but you have to keep in mind it does not completely rule it out. You interpret the ECG in the context of that patient's history and risk factors for heart disease. A normal ECG in a person less than 40 may be enough to rule out cardiac disease, but after 40, not so much. Pulse oximetry is important. It's easy to obtain, and it tells us a lot about that O2 level. Older adults or patients and those with risk factors might need diagnostics of cardiac enzymes, stress testing, and I put in parentheses that's less reliable in women because of the breast tissue, and or coronary angiography. Chest x-ray may also be useful in detecting cardiac and pulmonary abnormalities. And then one example of a diagnostic rule-out would be like an empirical course of a proton pump inhibitor, like Protonix or Prevacid or omeprazole, would be a reasonable first-line means to diagnose gastroesophageal reflux as a source of the chest pain. So I want you to just look and review that information on diagnostics. Management and treatment really depends on the cause of the disease process. What's the etiology of this chest pain? Exclusion of coronary artery disease and life-threatening causes of non-cardiac chest pain is absolutely the first step. But if the cause is GERD or musculoskeletal or pulmonary or psychiatric, all of your management and treatment is going to be guided by the appropriate interventions. And our textbook does a really good job on page 449 of drilling down into differential diagnoses and different management techniques of different conditions causing non-cardiac chest pain. Referral, for instance, or example, lack of response of gastroesophageal reflux. As a non-cardiac chest pain, you'd refer them to a gastroenterologist. But treating GERD with the standards of care is within our purview as nurse practitioners. However, if they don't respond well, we've got to go one step further because there's so much more to consider when they have a poor response. Abnormalities on a chest x-ray, such as a mass, you would send to a pulmonologist. And these are things that I know you realize, but I'm just reviewing. Patients with pulmonary embolisms require diagnostic tests such as D-dimer and a spiral chest CT. And there's a great referral review box on page 450. And I want you to look at those things. Clinical signs warning immediate transfer to a higher level of care. And I think we would be the first to have 911 called if we identified a immediate patient emergent need. Patient and family education has got to include that they're clear what the non-cardiac chest pain can cause significant morbidity depending on the cause, and they've got to be clear. They have to understand their diagnosis because chest pain's frightening. So you really need to drive home what is the rationale behind your diagnosis and what is the possible complications and what's the management and treatment. And then educate to recognize cardiac, pulmonary, and musculoskeletal pains and the actions to take. You know, people can have more than one problem or one cause. So we have to always remember that and educate our patients and families. If they smoke, you have got to include smoking cessation counseling. and then medication instructions so that you can have a positive outcome. Just verifying they understand why you're treating this non-cardiac chest pain and how, and then bring them back in follow-up so that you can verify that what you have actually put in their treatment plan, that they are complying and they understand. Thank you.